thick, heavily keratinized areas are there. So this is an example of the proliferative leukoplakia. This is commonly seen in females. So there is strong female predilection, and it can also be present in patients who do not chew tobacco. So if such thing occurs, so and if it is involving adjacent mucosa also, that means multiple area involvement is there, then one should definitely go for biopsy and check for dysplastic changes, because this type of lesion, it has a high malignant potential. So as we have seen the various types of leukoplakia, let's see the staging of leukoplakia. The staging of leukoplakia is basically done for uh, easy management of the lesions. If you see, it is the staging is done under four headings: size, clinical aspect, pathological features, and the site. So size, it can be less than 2 centimeter, or it can be in the range of 2 to 4 centimeter, or more than 4 centimeter, or the size which is not specified. The clinical aspect, it can be homogeneous, non-homogeneous, or not specified. Pathological features can be no dysplasia, mild dysplasia, moderate dysplasia, severe dysplasia, or not specified. For this, histopathology has to be done. And the site involvement can be all sites excluding floor of the mouth, tongue, or only floor of the mouth and tongue, or not specified. So size site 1 and site 2 is the in which the central non-keratinized area of the oral cavity, that is the oval area, is involved, floor of the mouth and tongue. So the highly malignant potential areas are there in the S2. Now, the general rules of staging, you should be remember that if there is a doubt regarding allotment of correct L, S, C or P category, we already have seen what is the L, S, C or P. So, if there is a doubt regarding allotment of the correct L, there is a location, site, the size, site, then the histopathology, category to a case, then the lower category should be chosen. So this will always be reflected in the stage grouping. And in case of multiple simultaneous leukoplakia, that means in the oral cavity, multiple areas are having the leukoplakia. The leukoplakia with the highest size or the highest S category should be classified. And in case of multiple biopsies of a single leukoplakia, or biopsies taken from multiple leukoplakia, okay, in case of multiple biopsies of a single leukoplakia or biopsies taken from multiple leukoplakia, the highest pathological score of the various biopsies should be considered. So while staging, these general rules of staging should always be remembered, and accordingly the staging will be done. So what is the final staging? There are four stages: stage 1, 2, 3 and 4. So stage 1 includes the earliest lesion, that is, they are non-palpable, faintly translucent white discoloration, means between the pre-leukoplakia and leukoplakia. In stage 2, localized or diffused slightly elevated plaque of irregular outline is available. It is opaque white and may have fine granular texture. Whereas stage 3 is a thickened white lesion showing indulation and fissuring. So stage 2 will include the speckled type as well as, and in the stage 3 the proliferative type is included. Now let's move on to the investigations which needs to be done to check for the dysplastic lesions. Brush biopsy is an important investigation with the help of which one can know the dysplastic lesions. As you can see in this image, this brush is available, which is scrubbed or rubbed against the patch, and then the cells which get adheres to the brush, they are then laid on the slide, and uh, after staining of the slide, they can be then viewed under the microscope for any dysplastic changes. Further staining can also be done. There are various staining techniques with the help of which one can see the dysplastic areas in lesion of leukoplakia. So toluidine blue staining can be done. In this, the patient is first asked to rinse the oral cavity. Then, after that, toluidine blue stain is applied to the mucosa. After that, the patient again it rinses with 1% aqueous solution, 1% acetic acid, and then the lesion. The part of the lesion which retains the stain is the area which has probably the dysplastic changes. So from that particular area, biopsy can be taken, which can help in confirming the presence of dysplastic lesion. So toluidine blue staining is also an important adjuvant technique of uh, knowing the area where there can be dysplastic changes. So after the histopathological examination is done by an incisional biopsy or excisional biopsy, the diagnosis can be given whether the patient is having just hyperkeratosis with or without dysplastic changes. So the differential diagnosis includes the lichen planus. See in this particular image, this is the tongue showing homogeneous type of lichen planus. But at the periphery, you can see fine white striae, which helps in differentiating this lichen planus from a homogeneous type of leukoplakia. Leukoplakia will never show the Wickham's striae. The second image is of a candidiasis. You can see thick keratinization of the area of the buccal mucosa near the commissure. But if you see, if such lesions are treated by antifungal, they respond very well and the lesions they resolve. Whereas leukoplakia lesions do not resolve completely with the antifungal therapy. Antifungal therapy only helps in reducing the keratinization, but complete resolution is not there. This is an example of verrucous carcinoma. You can see thick proliferative white areas. So this can be confused with proliferative type of leukoplakia. So definitely even proliferative has a high malignant potential. So biopsy is mandatory on the first visit itself. This is the example of cheek bite lesions. Chronic cheek biting can be there in patients having anxiety, depression, or any sort of psychosis. So because of that, the mucosa can have a whitish appearance. So in this history taking plays a vital role. If the patient is asked regarding the habit, then it can be very well disclosed that the patient is not having the habit of tobacco, but rather chronic biting. So chronic biting irritates the mucosa, and because of that irritation there is hyperkeratotic lesion. In lupus erythematosus, which is an autoimmune mucocutaneous condition involving various systemic conditions also, there can be mixed red and white lesion, giving an appearance of a nodular or a speckled leukoplakia. But one thing should always be kept in mind that if lupus erythematosus being a mucocutaneous condition, other area involvement should also be sought for, which is not there in case of leukoplakia. So that will help in differentiating this condition. This is a verrucous leukoplakia. You can see a small lesion having papillary projections, very peculiar for this verruca vulgaris, which is a viral entity and which can be present in multiple areas in the oral cavity, and which after excision can again recur in the oral cavity, which is not a feature of leukoplakia. This is an example of leukoedema. This is the buccal mucosa showing an opalescent pale hue of whitish area. So this is leukoedema is basically a variation of the an anatomical variation which is very commonly seen in heavy smokers and in black population. So the one way by which we can differentiate it from leukoplakia is that first of all history of heavy smoking. Secondly, if you stretch the cheek, this lesion will disappear. So, which is not a feature of leukoplakia, which persists even after stretching of the buccal mucosa. So, that way it can be differentiated from leukoedema. Next is the white sponge nevus. Now, the white sponge nevus, it is basically an autoimmune condition, basically a mucocutaneous condition, and an inherited condition which it involves the buccal mucosa. Um, the major part of the oral mucosa is involved rather than involving a localized area. And the lesion is present in the oral cavity since early years, since childhood, and it can be familial also. So in the family, even other members can have similar lesions. So all these history, if taken adequately from the patient, then it helps in differentiating it from leukoplakia, which is an entity seen in the middle age and in the older population, and specifically a localized one rather than being a generalized one or involving a larger area.